Hello and welcome to the Nurse Rosa's Insights podcast. I'm your host, Nurse Rosa Hart, and we are live at VIVE. Today, I get to interview Dr. Nick Patel, and he's going to share with us his story as well as his billion-dollar idea for the future. So thank you for joining me today.
Great to be here. Thank you.
Yeah. So tell me a little bit about your background and what brings you into the healthcare innovation space.
Yeah, so I'm a physician. I'm an internal medicine physician, practiced over 2 decades as internal medicine, as a hospitalist and primary care physician in South Carolina. And I was also the chief digital officer for that organization for a very long time. And now I advise large health systems, health tech, and private equity. So I kind of see all signs of healthcare, both the operational side, the investment side, and the new technology that's trying to disrupt and help a lot of the challenges that we have in healthcare.
Yeah. And so you have kind of a unique perspective there, because I think a lot of people stay in their silos and don't really venture out into other people's silos because they don't even know how to communicate about those topics. So the fact that you've worked in direct patient care as well as in the technology side of things and then also business, like that's quite a connected web of things. And are you mostly acting as a consultant in these roles now?
Yeah, now I do. So a lot of health systems invite me to come in as a digital health strategist or digital transformation strategist, because a lot of health systems try to struggle with how do you connect clinical needs and enterprise needs to technology. I think a lot of times what happens is health systems start with the technology and then try to find a clinical use case, versus you should know your clinical use case and then find the right technology that help you solve that challenge. So I try to connect both the clinical and operational side.
Are you involved in like the development of the building of the technology side, or more the evaluating of things that are already built?
Yeah, so on the technology side, I help with companies that already have technologies, help them with their product roadmap, understanding their workflows, where we really fit into a health system, because health systems get asked to buy all kinds of technologies.
Yes.
And it really becomes very confusing to the health system of which one they need to partner with.
Yeah.
And so I help kind of move them through that noise of where do you want to position it, and what are the right health systems that really need the technology, because sometimes it may not be something a health system's looking for. Their focus may be more virtual nursing versus patient engagement and digital front door. So you have to kind of understand where does the technology actually fit into their enterprise strategy. And on the health system side, we want to make sure we actually try to solve the clinical issue. Like one of my large health systems that I work with in the North is having challenges with staffing. And it's a huge issue right now, especially with nursing.
Who isn't having trouble with staffing?
And the cost is high, right? The agency spend is almost twice what you pay an employed nurse. And so what happens is that now you're having nurses see more patients on the floor, right? So the ratios have become challenging, and nurses are burning out and leaving the industry, so which obviously adds to the challenge. And so there's technologies that can help augment nurses, but make sure that it's done in the right way. So what is done virtually and what is done by the nurse at bedside.
So are you, as a physician, bringing in other nurses to help consult in these conversations? Because I feel like a lot of the times we look to physicians for their thought leadership on these issues, but you might not know what the nurse is actually going to be needing. And so do you kind of facilitate those conversations as well?
I think it's important to make sure whoever is going to be the user of the technology is at the table. And unfortunately, a lot of health systems, they don't have the right governance set up that allow those folks to be at the table. At that system in the North, we really had the CNO, we had all their nursing leaders at the table.
Good.
And so and also that system has unionized nursing.
Oh, wow.
So it's even more challenging. You have to make sure that we're following the rules, and so it doesn't cause any disruption from that perspective. I think it's very important as governance, depending on what use case you have, that the work groups have those leaders leading it. So virtual nursing versus care coordination, two different sets of folks, but connected. Right. So you have a patient in the hospital, is getting ready for discharge, may have social determinant challenges to get them home. Well, then we need to make sure PharmDs are involved, care coordination is involved, and that they have a smooth transition. But the technology can be the same. And I think the mistake a lot of people make is they choose a new technology for every clinical use case or operational use case, when you should be looking at it from a platform play. What else can we actually do with this technology? and then look at your core EHR, what functionality it can do so you don't duplicate efforts.
Yeah.
And it's also very expensive to do those things.
Exactly.
Yeah.
Do you have anything that you like to look back on as far as where you feel like you've made a real impact with an organization that if you're frustrated, you look back on, well, at least I did that one thing and I know that made a difference. What do you hold on to?
I've been blessed that I have had a few of those great experiences, and also not so great experiences.
Right.
But the ones that stick to me is when we really made an impact in the community and improving access to care, and especially access to wellness, behavioral health, and closing care gaps. And we used chatbots. And remember when COVID happened, every health system was getting calls. Do I have COVID?
Right.
Shortness of breath, cough, and lack of smell. And so we set up a chatbot that we allowed any health system to use, and to reduce our call volumes to the access center by 40% on day one.
Wow.
Just by an app that used, again, evidence-based medicine and making sure that the person went through an algorithm to say, no, you're okay.
Asking screening questions about their symptoms and kind of letting people self-select.
Exactly. And it had escalation points. So when you really needed to get seen, when you really needed to get COVID tested. And eventually we matured that when the vaccines came out. So, during COVID, we're kind of learning as we're going, as we understood more about COVID, right? And then the vaccines came out. We had a vaccine chatbot. And then in South Carolina, for example, you needed a letter from your doctor saying that you're okay to go back to work.
Oh, yeah.
To return to work letter. Now, how would that be possible to get a primary care doctor to write letters for everyone, right? And
well, first they have to have a primary care doctor.
A lot of patients didn't. So what would happen to all these folks? So we set up an algorithm that went through the symptom checker, that went through everything, and asked the vaccines and all that, and then actually printed out a letter for them signed by the medical director that they can use to go back to work. So it was really good. And it's totally frictionless, and it didn't require any sort of interaction with people to write the letter for you.
Right.
So those types of things. And then we did a lot around digital health. We went to full 95%, probably all our visits were virtual on the ambulatory side.
Yeah.
And so we allowed that to, virtual visits to happen. But a lot of cool things happen. Like, as a primary care doctor at the time, I don't get to see what's in your house. I don't get to see your medicine cabinet. When you're doing a video visit, you go, Mr. Smith, can you go to your medicine cabinet and show me what you're taking? Because they're confused about what they're taking. And you learn very quickly, people collect pill bottles. And they have them for like
about 20 years.
20 years. Like, let's get rid of all of that.
Yeah.
And here's the ones you take. And then
start fresh.
Start fresh. It also let you see their house to see how cluttered it was. So fall risk.
Now that's why people don't want to have people come in. They're like, I don't want you throwing away my stuff.
Right. Well, it will at least give them some guidance to say, you may want to move these things out of the way because we don't want you to fall.
Exactly.
Now, there was a disconnect a little bit because what we found is the Medicare and older population, 70 and older, were having struggles doing video visits. So they would do mostly audio visits.
Oh, and then you couldn't even see those elements.
You couldn't see those elements, but you can talk to them. It's good for established patients that you've known for years and years that everything is good. They may need a refill. They may have an issue, but you can solve through it. And we still had a mechanism for them to come in. We would have tents set outside of the primary care clinic so they'd actually come through and we can see them there. And so we had some mechanisms to allow people to come in if we needed to see them. But those are types of technologies that I was very happy with. And then obviously closing care gaps. So we did a program with the Department of Corrections and all-female prison, and we found so many females have not had breast cancer screening. And we found a lot of women who actually had stage 1 or stage 2 cancer.
Oh, yikes.
And had to have diagnostic and biopsy. So, to me, that's a population impact that is difficult for a primary care doctor who on a panel may have 2,000 patients.
Yeah.
That's the impact you're going to make is 2,000 people. Right. But if now with use of technology and doing things more population based, I can impact 100,000 people or more. So I think that's where medicine is moving because there's not enough nurses and doctors for everyone and the aging population. So you're going to have to start thinking outside the box.
That is so true. And I mean, that's why I got into podcasting initially. So as a stroke nurse navigator, I call people after they have a stroke. And for years, I would have the same pretty much conversations over and over and over, provide the same education, but also identify, you know, special things that they need, and who could help them with their modifiable risk factors or their other complications like headache or difficult conversations like sex after stroke. And I was fortunate enough to be invited to create the Stronger After Stroke podcast. For them to encapsulate those answers to questions. And then now it's being heard in 76 countries.
Wow.
So
that's awesome.
I hear what you are saying, okay, about expanding the reach, because I don't have time to have a 30-minute conversation with every single one of my own patients, let alone reach all the other people I know are having the same issue. And so it does feel so good to know that you're able to touch these lives even if they don't even ever know you exist. To just know that something good is growing out of what you built, right?
And you incorporate their loved ones in the conversation.
Exactly.
Right? I mean, sometimes it's like mom and dad, they need help, right? So it's their son or daughter, maybe it's a churchgoer, you know, that happens. I have patients, elderly patient bring in from someone from their church, and they're the primary caregiver. Right? And so it's important to be able to communicate with the people who are actually doing the work outside of the office. I mean, you get, if as a primary care doc, you get 15 minutes with a patient if you're lucky. And you don't see them for another 3 to 6 months. You have no idea what happens in between those visits.
Let me ask you about a pain point I'm sure you encountered. How frustrating was it for you filling out FMLA paperwork?
Very frustrating.
Tell me more about that.
Well, I mean, providers are busy, number one, and they're trying to document, they're trying to see as many patients as they can. And then you get back into your office and you've got folders up to here to sign paperwork.
And are all FMLA paperwork options the same, or are they different from different employers?
Different, slightly different. I would say 90% the same. And a lot of that information, if again using AI and data that's already in the EHR, could be auto filled out. And so it should be more of a sign here sort of thing and verify, versus having to fill out pen and paper. Which is, we still do a lot in healthcare. Not only that, we get those nursing home orders. Those are paper. Right? I mean, we had
hasn't things like point click care helped with that, or is that more on the patient facing side?
I think that's more on the patient facing side. But I think we're trying to digitize it more and more. But a lot of these nursing homes and other community hospitals or clinics, they don't even have EHRs, or they may be using some form that doesn't allow us to have interoperability. So it's still being sent over as a fax. You sign it, it's faxed back.
Do you know of anyone who is developing a way to like automate FMLA paperwork so that if the physician's like, yes, I approve this, click, all their like epic information is transferred into it, so it's not taking up so much of the PCP's time, and they're punting it to neurology, who's punting it to cardiology, who's punting it to another specialist who's like, I haven't even seen this patient in 2 years.
Exactly. So there are companies actually here that do a lot of generative AI work that is moving in that direction.
Well, let's get that.
Because that, I think, is going to, again, it's going to help with burnout. It's going to get the patient, what they need filled out.
So they don't lose their job. Or so their caregiver doesn't lose their job for taking them to their follow-up appointments.
Exactly. Now, what happens is, again, it's a great partnership usually with the provider and the nursing and the back office. So they fill out as much as they can because they've seen them so many times, and they know how typically where you need to fill out certain things. So but
this is not an element that requires physician or nurses
100%
to do it. That is a waste of our clinical time.
100%, and that's why it takes 2 days for someone to return your phone call, because they're filling out paperwork for something else. So yes, this is where we need to leverage technology to do those menial tasks that we're still doing manually in this digital world.
Which you could qualitatively make the assessment in your mind, yes, I do agree to do this, and you check a box and then it's done for you. Like, that's what needs to happen. Is that, I'm sorry, was that going to be the answer to your $1 billion question? Because I don't think I got to ask that yet. So if you were given a grant for $1 billion, how would you like to see it used to have the most sustainable impact?
So first of all, the $1 billion question, although it's an extremely important one, I want to make sure that the $1 billion goes to the patients. Because I think in healthcare, we're already spending more than any modernized country in the world when it comes to providing healthcare, right? Trillions of dollars. But what is it? You see
what these companies are spending making these improvements when you're in these conversations.
Yeah, I mean, Johns Hopkins spent $1 billion on their Epic rollout, right? I mean, these are not small dollars, and sometimes what happens is that they can't grow their organization because they're having to spend money on these other things, right? And so it's really challenging when you look at if I was given $1 billion, what would I do? I would, number one, focus on provider burnout and staffing shortages, number one.
Yeah.
How can I make their life better so I can bring joy back into what they do?
Do you
Yeah.
have a how for that?
Yeah, so one thing that we do spend a lot of time on causes one of the biggest frustrations when they've done multiple surveys asking providers, why are you burnt out? It's documentation. So a lot of these companies now, used to be, you dictate and then you made a lot of errors. But now with generative AI, it's really, you're just having a conversation, just like you and I are having a
The
conversation.
ambient AI can pick up on it and
Correct.
extrapolate from
Extrapolate for it. So like, I don't have to go to physical exam and I'm looking at your knee. I can say, hey, your knee has some crepitus in the right knee. Your range of motion is limited here. And I'm talking to the patient as I'm saying it, because you want to explain it.
Making eye contact,
Yeah,
maybe making physical contact with your assessment.
Exactly. You don't have the back to your patient clicking away in the EMR. So this allows for the generative AI to actually put it where it needs to go. And maybe as these companies are continuously partnering with other reference libraries, it's now getting insights. So imagine if you're telling me your symptoms, I'm listening to your symptoms, I'm asking you questions again, and then it's querying in the background someone that looks like you, your age group, and it also knows your past medical history, and go, Nick, you may want to think about these things as a differential diagnosis. This could be really great when it comes to rare disease detection, right? And so using real world evidence in the cloud that is pulling this information in. A lot of this isn't really connected yet, but that's where the next stage is going to be.
Yeah.
Because dictation and writing a note is one thing, but getting insights from what you're saying and what the patient's saying is the next generation.
Yeah.
Right. And then you think about automatically understanding billing, automatically understanding HCC coding. So now it's a diabetic. Nick, you have him labeled as a non-complicated diabetic, but this person's had a stroke and has stage 4 kidney disease.
If that's not a complication, what is?
Exactly. Right. So from that perspective, so I would use a good portion for that. Second piece is I think that we need to start focusing more on ambulatory practices versus acute.
And preventative.
And preventative.
Yeah.
So I think focusing on
Would you
that,
include food as medicine as part of that?
food banks, access,
Supporting farmers who are producing
100%.
sustainable farming practice.
Yes. And I think there's a payer has to partner with you on that, right? Health systems can partner and do these things, but the payers have to also incentivize the patients to eat healthier, right? Maybe reducing and gamifying and lowering your premiums because Nick walked certain miles, steps a day, or Nick bought certain fruits and vegetables and is taking and med adherence because he picked up his is taking his medications. And by the way, he's also in a chronic disease management program, is checking his blood pressure's going down, weight's going down.
Yeah.
So now you start to get all this information, right? I think what we struggle with is we get so many streams of data now, we don't know what to do with it.
Exactly.
But
We need help organizing
We
them.
need help organizing. So if we can use an AI agent to help organize and do a true patient 360 of what needs to happen and alert us to say, Nick is going down the wrong path. He may end up in the ER. You need to intervene and do X, Y, Z. And then engage your clinical staff to do that through virtual visits or in office visits is what I think should happen. But I think at the end of the day it's not so much how much money we spend in these technologies is what impact it truly makes.
Well, and being specific or being strategic in how we spend money to have the most impact.
Correct.
And not just say, oh yeah, we spent that budget this year.
Correct.
Or
Correct.
we built a wing of this hospital that has somebody's name on it.
Right.
Well, how about we make sure we don't have people to put in that wing of the hospital through prevention?
Correct.
Yeah. So, I mean, it really does matter how you choose to use those dollars. And you're right.
Yeah.
There's a lot more being spent than is having that sustainable impact.
Yeah. We haven't in healthcare still seen a massive impact in that billions and billions of dollars spent. I would venture to say trillions of dollars spent since the HITECH Act. So patients are still very frustrated. They can't get in. They can't, spend enough time with their doctors. It's 6 months to get anything done. Why is that? We've spent so much money on technology so far, trillions. and we haven't seen the impact. If anything, we've had some unintended consequences of burnout, people leaving the profession, which has compounded the challenge of having enough access to primary care, right? So obviously we're not doing something right here, and we're putting money out there, but what return are we getting? When I advise health systems, I want to make sure there's a KPI on every single clinical use case and operational use case. So if you're talking about virtual nursing, or you may be talking about patient throughput capacity management, think through what that KPI needs to be. And there better be an operational one, a clinical one, and a patient-directed one, and making sure that there's one there. Because at the end of the day, if you're doing it just to put technology in, then you're not helping anybody.
Right.
You know, and I think it's very important that whenever you have new technology, to your point earlier, is to involve the right key stakeholders at the table. You know, I'll tell you a great example. When we went and got an EMR, IT came and put computers on walls, right? It happened over the weekend, and we're about to go live on our EMR. Well, guess what? I had my back to the patient. It's the only way I can. It was right next to the exam bed.
No.
And I had my back to the patient. And
There
so,
went your patient experience point.
exactly. But to IT, that was success. What did they do? Their success was putting it in, secure, plugged in, working.
Mission
Success.
accomplished.
Check mark. But from a business perspective, from the provider perspective, which is why we're in healthcare, it was an epic failure.
Yeah.
Right?
Literally with Epic.
Yeah. Yeah. Well, it wasn't epic at the
It
time.
wasn't Epic's fault.
Yeah, it wasn't
where
Epic's
the thing
fault,
was
but
installed.
It was an EMR.
Right.
But I will just say that it was, again, very disruptive
Yeah.
to that patient and provider relationship.
Yeah.
And, you know,
Sounds
when I
like
used to, I was a hospitalist for half my career, then I went to primary care. And one of the things is I always write a little personal story about my patient. So if I was seeing you, it's like, oh, you might have said, oh, you're going to Hawaii. And I'm going to see you in 3 months, right? I always put that in my note. So when I walk in the door to see you, how was your trip to Hawaii? Did you have a great time? Right? You don't just go start in to say, hey, your blood pressure's high. You know, you ask them, how was your trip? You kind of ease them into the conversation.
Well, and remind them and yourself that you're in a human interaction.
That's right. That's right.
And that is the best therapeutic communication example. Thank you for sharing that.
Yeah, I mean, I think providers, all of us in healthcare in general, should treat others as we want to be treated one day, because that's an absolute in life, and they're not a lot, but that's one absolute in life, is that we all will be patients one day. And the question is how will you want that care delivered to you, right? So if we're gonna put these barriers, then you'll experience those barriers as well. Right. I mean, I was just listening to the cancer moonshot conversation across the way there, and it was talking about, you know, cancer is still a very transactional thing, right? You got cancer, and then you go through all these pieces. It's very transactional. It's not experiential. It's not going through a journey with the patient on their cancer journey, right? It's not about coming in, get diagnosed, and biopsy to chemo to radiation to surgery, right? All those things can happen. But there's a lot of questions that person has about everything. They also want to validate, is this the best course of treatment for me?
Right.
Or is this a cookbook that your recipe you're following?
And how do we know that this isn't going to backfire in my specific use case?
Exactly.
Yeah.
Because now with genetics, we understand you as a person, your demographics. If I know your genetics on top of that, then there are probably thousands of you out there who've gone through something similar. Yeah. You're not alone in it.
Right.
Now, how about if I can find out what was the best outcome out of everyone that did what has gone through what you have, and then choose the best based on what others had similar results with.
Yeah.
And then how I connect you to people like you so you can have conversations and so they can kind of help you through the journey.
Yeah.
Right. So
we need that community support of people who understand.
Exactly. So there's a lot I think we can use money like that. Unfortunately, money like that doesn't come easy nowadays. But you know, so providers and health systems are trying to choose their top priorities, and because staffing is such a huge issue right now, it is a major focus for a lot of health systems. Is how do I support my providers? How do I support nurses at the bedside? You know, how do I do this? And starting there, because they're leaving. And we have to start thinking differently about how we do work with technology.
Well, I'm so thankful to have your voice in this conversation, and thank you for prioritizing including nurses' voice in the conversation.
Absolutely.
We all have to think about each other.
Absolutely.
If you have enjoyed this episode of the Nurse Rosa's Insights podcast, please subscribe and follow on whatever platform you're using. If you're watching on YouTube or if you are listening on an audio platform, we are on the Health Podcast Network. And I would love to hear from you. If you would leave me a comment and let me know if you've learned something from this episode or if there's another billion-dollar idea you know of that needs to see the light of day so it can become a reality. Let me know about it, and I'll see you in the next episode.